In this video, we'll present a case of a large thoracic arteriovenous fistula in a pediatric patient. The case is a 3-month-old baby boy who presented with lower extremity weakness, progressive over several days, and hyperreflexia. He had a diagnosis of HHT. On examination, he had decreased muscular tone and weakness on bilateral lower extremities. His MRI of the cervical, thoracic, and lower spine demonstrated vessels on the front ventral side of the spinal cord with enlarged draining veins, and all these features were consistent with a arteriovenous fistula or arteriovenous malformation. Diagnostic angiography demonstrate, as seen here, a very large high flow direct fistula arising from T10 on the left side, but also the fistula arises from the same level, T10, on the right side. So the fistula has two major arterial feeders, both of them at the same level, T10, and both arterial feeders meet in the midline to form this very large abnormal connection and a draining vein. The connection has a really big pouch or fistulous pouch, as you can observe. So under general anesthesia, we catheterized one of these branches going into the fistula and navigating a microwire and a microcatheter. We advance into the feeder. There is significant tortuosity, and we have to do several maneuvers in order to make that microwire make those turns. Then finally we got into the fistula. We have to use a different microwire. That small microwire went really nice into the main arterial feeders. Once we are in the true fistulous connection, we advance the microcatheter, keeping the guide catheter stable, because as you can observe, every time we advance the microcatheter, the guide catheter gets pulled back, wants to come out. So we use this microcatheter and getting into the fistulous portion. We really want to get into the connection of the fistula. Then here we go. The microwire is finally in the enlarged venous pouch. However, the microcatheter didn't want to advance that further out, and then finally it did it. We decide, then we perform a micro injection run to have better visualization of the anatomy and high versus low flow into the fistula. We decide to first put some coils, and the reason why we did coils instead of a liquid embolic agent such as Onyx or MBCA is because we wanted to have really very good control of the embolization material. The anterior spinal artery originates from these large branches, so we didn't want to take the risk of some material embolize into the anterior spinal artery. So we then proceed with multiple coils, different sizes. We start with a framing coil going into that really big draining vein pouch, and that loose coil will slowly promote thrombosis. And then we start packing that arterial feeder using helical microcoils. This is coil number 3. We then perform a run that we can see is slow decrease. The slow flow significantly decrease. We keep on adding more coils to really compact that feeder artery until we obtain adequate obliteration of the fistula. Another run, there's still some filling through the coils. We added another coil, maintaining the microcatheter in position. There was some resistance and some difficulty trying to deliver this last coil. We finally did it. And you can see that there is already some thrombosis of the main arterial feeders, and you observe how the two arterial feeders meet in the midline, and from there is only one arterial feeder going into the fistulous portion. So there is successful embolization, and you can observe the two feeders meet in the middle, but as I was describing, the anterior spinal artery or the thoracic spinal artery originates here and gives blood supply to the artery. Patient did very well. Follow-up MRI demonstrate complete obliteration of the fistula, and the patient recovered completely. Thank you.